Good morning, everyone. EllenWhelan. I'm from CMS. I've been at the Innovation Center for about 5.5 years now, which is about as long as it's been around. And for the past 1.5 years, I've been at Medicaid as the Chief Population Health Officer. But also, I'm a pediatric nurse practitioner by training. I spent a lot of time doing adolescent health care in a community-based center in Mantua in Philadelphia, which was the crack capital of Philadelphia at the time. So just first of all, I want to thank you for the work that you're doing in this workshop as well as the series, because it's so critical to the future of where we need to be going and for the most vulnerable populations. Today I'm going to talk about delivery system reform. I'm going to talk about federal funding of healthcare, which might be something that's a little bit up in the air at the moment. And so I'm going to talk a little bit about what we've been doing over the past 5 to 8 years, and we'll actually spend just a slide or two talking about some regulations that have been in place that I think why we're going to continue to do what we're doing. I think most importantly, we're going to be doing this because we want to do exactly as Ben just said. We want to be creating new payment models that are supporting the kind of care that you all are hoping gets delivered. This slide here is something that you all know. On the left, it's the characteristic. It is the system we have now. The right is the system that we want now. And I am a believer. Never thought I would be at CMS doing payment policy, but as a clinician, I saw firsthand when you changed payment, you then changed the way care was delivered. And so there in the lower right-hand corner is where we're moving from fee-for-service. When we pay an individual provider to do a specific service, oftentimes mandating what that setting needs to be, it's limited, as Ben just did a wonderful job explaining, and as the other folks have talked about, that none of these models can happen when it's a purely fee-for-service system. We're moving to value-based purchasing, ACOs, episode-based payments, medical homes, and this is what we've been doing over the past 5 to 8 years. At HHS, we have our own triple aim, because that's a registered trademark, I think. We have better, smarter, healthier as our triple aim. Better care, smarter spending to create healthier individuals, healthier families. And what I'm going to talk about today is delivery system reform and the goals that we set for ourselves at HHS, and why I think that those goals will continue even in a new administration, in part. And then Medicaid, how the specific, if we're moving towards global payments, and we are, how Medicaid can help make it happen as it stands now, a bit of an on-ramp for folks that maybe aren't ready to take and jump in and take that global capitation. I think I'm not going to do the Innovation Center. I'll see how much time we have. I'll make these slides available. What I was going to talk about at the Innovation Center is examples of when we have seen payment change, how there have been interdisciplinary, strong, embedded teams that have been able to create not only better outcomes, but also much more cost effectively. So our goals at HHS, when Secretary Burwell came in, we acknowledged that we spent much of the first number of years of the Obama administration looking at coverage with Marketplace as well as Medicaid expansion. And she challenged us to say, now that we are moving in the direction of having better coverage, what can we be doing about making sure that that coverage is something that is better, healthier, smarter? And so we identified 3 areas where we at HHS are focusing. How we pay providers, clearly a huge thing that CMS can change. How we deliver care, sometimes directly on how the care delivery, oftentimes by the way that we change the payment model, and also distributing information. HHS holds lots of the data. We at CMS in Medicaid and Medicare, but also across HHS, and I think much of what we're doing is now trying to also look to linked data sets where we have an intervention in one silo creates a success in another silo. How do we compare that? How do we measure that? How do we look at that as we're moving forward? So I'm going to spend most of the time today just talking about payment, though. Very busy slide. I've got a couple of these, but the takeaway message of this very busy slide is the 4 columns there, categories 1, 2, 3, and 4. And this was when we set our goals to improve payment and move away from that fee-for-service system. We needed something that we could measure ourselves on to see how we were doing. So category 1 we talk about is now just fee-for-service, straight fee-for-service, no link to quality, the same way it's been all along, all about volume, quantity, and no looking to see if ultimately those outcomes have been improved. Category 2 is the next step where we actually still are in a fee-for-service system, but we link the payment to some kind of quality. It's usually in a upside risk or a benefit that the providers will get when you do certain things and we see different outcomes. You will get, mostly it's a bonus. Categories 3 and 4 we think about as alternative payment models. 3 is still based on a fee-for-service infrastructure, but we've done it a bit differently. It's a bundle, it's a shared savings. It's a different way of putting that together and looking towards what we think category 4 is, that population-based or the global payment that Ben talked about, where I think that's the place we really can do the best job doing integrated team-based care in a way that is seamless to the patient and then also seamless to those providing the care. So these categories is what I'm going to talk about now in the next couple slides. When we announced January 2015, Secretary Burwell announced that we wanted to make goals to change Medicare fee-for-service, because that's all we really have 100% control over, from fee-for-service to either linked to quality or to those alternative payment models. So the first goal was getting to 30% alternative payment models, that category 3 and 4 by 2016, 50% by 2018. And the goal 2 was to have almost all of the payments linked to quality somehow. So in any of those categories 2, 3, and 4, 85% 2016 and 90% by 2018. The other challenge was to continue testing new models of care so we could try to see how we're moving in this direction. And also the creation of a learning and action network, because we acknowledge that it's not just CMS. We can't do it alone. It's not just HHS. Unless we get all payers thinking about this, lots of stakeholders believing that this is the way to go, it will never happen. We'll never get to that tipping point. So how we've done. 2011, the colors there, the dark blue is the alternative payment model, so those categories 3 and 4. The lighter blue is links to quality, and the gray is just fee-for-service. So you can see in 2011, there were no alternative payment models. We didn't really have an accountable care organization. 2014, when we set the goals. 2016, these were our goals, 30% and 85%. And in March, President Obama announced that we had met those goals already. So we're moving in this direction. And you can see where we're headed in 2018. Again, we can't do it alone, need to be convening stakeholders, incentivizing providers, partnering, especially with states because of Medicaid. And just want to put this slide up there. The website is at the bottom. This is our healthcare payment learning and action network. We call it the LAN, and it's a group of, it's a website that you can go on to, see lots of different work that we've been doing, working with, I think, 11 of the big 16 payers. So when we talk about benchmarking, when we talk about alignment, when we talk about some of these things, we can talk about it in a way that resonates with lots of stakeholders, including other payers. So the reason I went through all of that in the detail I did was to say why I think that this is here to stay. Although that was all done in the past administration, MACRA, which you may have heard of, which is we're calling now the Quality Payment Program, is a piece of bipartisan legislation passed in the House and the Senate. You can see there in red, I highlighted those numbers. Overwhelming bipartisan support, which hardly ever happened in Congress in the past couple of years. Changes the way we pay for Medicare and the way we reward providers. The 2,300-page regulation I'm summarizing in this single slide. There are 2 key parts. The default is this merit-based incentive payment system, where providers will be reporting on how they're doing on a number of measures, including quality, resources, quality improvement over time. And the second is an extra bonus for folks that don't have to even participate in the MIPS. If they're willing to show us that they're in an advanced alternative payment model from the Medicare Trust Fund, they automatically get a 5% bonus. The reason this is important is because those goals that we set out with HHS are supported and driven home, I think, by MACRA and the Quality Payment Program, which we believe is now the way that Medicare will be paying. So that merit-based incentive payment system is going to financially reward. The first year will be a 4% bonus for those that are doing well, up to a 4% bonus, those that are doing well on quality measures, on quality improvement activities, on their resources, and up to a 4% penalty. So it's a budget neutral, which goes up to 11% over time. So these providers that are doing well in fee-for-service and not looking at quality will be dinged, and participation in this advanced alternative payment models, which is that movement towards the global payment, will get that automatically 5% bonus. So it's a long way of saying that as we're talking about value-based purchasing, and there's all the uncertainty of where we're going in the new administration, we think that that's here to stay. And just a couple slides about Medicaid. So first of all, coverage. Although we talk about payment now, none of this matters if someone doesn't have health insurance. 32 states, including DC, have expanded their Medicaid program as part of the Affordable Care Act. 19 have not at this point. We've seen it has huge influence on the uninsurance rate for children. We now have a historic low of only 6% of children are uninsured. And nearly all of those kids that are eligible for Medicaid and CHIP are covered, over 90%, whereas in 2008, there was still about 20% of kids that weren't covered, even though they were eligible. These are some of the ways that we're moving now before we get to that global capitation. I'm not going to go through all of these, but I think the integrated care models are new ways, new alternative payment models that we're working with states, providing lots of technical assistance to help them get there. Health homes is something we've got now 30 programs in 21 states. It's got a mental health component for almost all of them, and we have quite a few that are focusing on children. It's an option that states can take advantage of. You can see 21 states have taken advantage of. So a lot of this stuff is wanting you to be aware of what states can be doing that they may not be, that you as advocates looking out for the health of children might be able to work with some of your states, your state legislature. We understand that it's expensive for states. They have to come up with their piece of it. Piece of the match, but if we can demonstrate, if we can talk about that business case of why this matters, then I think that we can go a long way of why this makes sense. I think, as Ben showed, those kinds of studies that we have done before that demonstrated that this can be cost effective, this can improve care while decreasing cost, will be ever more important to highlight as we move forward in the next number of years. EPSDT, the early and periodic screening, diagnosis, and treatment. The folks at Medicaid don't think that not a single state has maximized how much they could do there. It's screening for, it's prevention, screening, and diagnosis. So lots of screening could be happening and being reimbursed there that does not currently happen. Targeted case management are services that don't have to be in clinical settings, can be in all sorts of settings. Managed care authorities, we just had a huge regulation come out that states can be much more directive on telling managed care plans what they need to do, and having oversight was always something they probably could do, but we clarified that. I'm going to just do a couple slides here to talk about some of the things that we have clarified over the past bit of time to show what Medicaid, again, can do and in many cases is not doing. So informing states and reminding them it was their responsibility to do behavioral health screening as part of EPSDT, which is a required services. Letting them know valid and reliable screens for mental health and substance abuse disorders. Clarifying states the option to do peer support services when they're doing comprehensive mental health and substance abuse programs. An information bulletin showing that's encouraging states to adopt a full continuum of care with mental health conditions. And all of these are documents that are on our webpage that are 3 to 12 pages for each of these, explaining to states what they should be doing. Also making sure that we're not working in the silo. So with SAMHSA and NIMH, we did an information bulletin regarding evidence-based practices for older adolescents and young adults for their first episode psychosis with SAMHSA and ACF, the Administration of Children and Families, how states could do a better job with foster care, especially overprescription of psychotropic medications. Here's the maternal depression informational bulletin explaining that pediatricians could be billing, if we can find the right code. Sounds like I've got to talk to you at the break. They can be billing for maternal depression, which was a big deal, kind of making sure that that clarification was there. So none of this was new regulations, just clarification. And then just I'm going to quickly show, these are what our bulletins look like. So as Lauren mentioned, the McV program, the home and community-based services, the home visiting program, we wrote a bulletin with HRSA saying, here's what CMS and Medicaid can pay for, here's what HRSA can pay for, a state can do a better job doing a more comprehensive reimbursement for those services. Work with the Department of Education to clarify that care can be delivered in schools and be reimbursed by Medicaid. And working with HUD, Housing and Urban Development, to show that we can be covering all sorts of different housing-related issues. So I'm going to stop there and not go through. We can, again, make these slides available. I just, in the last slide, showed how we have very specific examples of when you have a new payment model, we can support care delivery models that are interdisciplinary, strong-based, strong integrated care teams, and also improving care and decreasing cost. And hopefully all of you will be continuing to carry our mantra to your states when you go back home, that this is the future and this is the way we hope that care will be both improved as well as cost effective in the future.